I'm at the University of Alabama at Birmingham, and the views here presented are my own. This is for everyone who wonders, what is the background of Medicaid? How did it come to be? It's important because you pay taxes for it if you're in the United States of America. 68.8 million Americans are on it, and another 5.7 million are on a very closely related program called CHIP. It's become particularly important because Medicaid was greatly expanded as a result of the passage of the Affordable Care Act in 2010, with most of that expansion occurring in 2014 and 15, and there's been a lot of discussion about efforts to reverse the Obamacare exchange and Medicaid provisions. The trajectory of the number of people uninsured in America since the passage of that law has been down. Particularly if you look at that dark blue line, you'll see that 18 to 64-year-olds who were historically the most likely to be uninsured have had a real reduction over time. Medicaid is a big component of the health insurance package. Of course, most Americans still get insurance from their employer. Medicare is somewhat larger, but Medicaid and the CHIP component are still quite large, as you can see in this graph. This is a graph that shows both spending and enrollment in Medicaid. The red line is actually for spending, and that's tied to the left side axis, showing that we're kind of approaching $600 billion a year in 2015. The blue line shows enrollment, and in this one, because it's combining in the CHIP folks, it's actually a little over 70 million Americans enrolled. Medicaid is about 10% of total federal spending, $368 billion. This is from the Congressional Budget Office, and that's likely to grow. Let's think about the history of care for people who are poor. This is actually a picture of I guess, a plague doctor wearing one of these protective suits they used back in ancient, 500 years ago in Europe. Before the 1950s, the way we looked at care for people who were poor or indigent was primarily as a matter of charity and alms. They were ad hoc, civil, religious, and voluntary programs. Almshouses for the poor, the aged, the insane, and the disreputable. That's actually a quote from the one from Philadelphia. But the almshouses became hospitals, like the Poorhouse of New York City eventually became Bellevue. Charity Hospital of New Orleans was also originally an almshouse. Here is a record of the history of the Philadelphia almshouse in 1732. This long resolution, which I won't read you in detail, says there was essentially a plan presented to the Assembly of Philadelphia because of the difficulty of all these poor people coming in from foreign ports and neighboring provinces, and people just didn't know what to do with them. So they proposed that the commonality spend money to build an almshouse and attach to it a hospital for the accommodation of the sick and insane. And of course, that became the Philadelphia Hospital. The 19th century saw the evolution of hospitals so that they weren't just for the poor and they weren't just seen as charity. They really reflected the professionalization of medicine. And here you see a picture of the Johns Hopkins Hospital. And this was not built as an almshouse, but as a place where scientific medicine could be learned, taught, and practiced. The general theme of our indigent care systems from 1950 onward was an effort to formalize the organizations and methods of payment for people who themselves could not pay for care. That included the establishment of Medicaid and Medicare, special kinds of money that were packaged to go to hospitals that took care of a disproportionate share of poor people, and community health centers. The run-up to Medicaid is really in the 1950s. There were federal grants to states to help care for the poor. They were not very much used. And then there were new federal grants, kind of building on the 1950s era, of additional monies to the states for medically indigent elderly, part of what was called then the Care Mills Act of 1960, and that proved important when Medicaid came up. People got money based on testing for means. They had to be poor. Just 28 states took up this option, and only about 1% of the elderly were getting benefit from this program before the passage of Medicare and Medicaid. And of course, 1965, you see Lyndon Johnson with Harry Truman next to him signing the passage of Medicare and Medicaid amendments to the Social Security Act. The arrangement of that law was kind of complicated, and that's why it's sometimes hard to understand U.S. health policy. Sometimes people refer to what was planned then as a three-layer cake arrangement. There was a payroll tax that everybody had to pay into to assure that they would get hospital care when they were elderly, and that was Medicare Part A. And that's sort of like a single payer system, almost a socialized medicine kind of arrangement with a little bit like Canada. Then there was a voluntary program which people could kind of buy into called Medicare B, but they would pay some fees when they went to see the doctor, with the rest coming from this voluntary program. And it was essentially like a federal government insurance model, something that doctors who were resistant to socialized medicine would be a little more comfortable with. And finally, the third layer of the cake, a federal grant to states for indigent elderly and certain others, Medicaid. It's a lot like that Kerr-Mills Act of 1960. You could think of it as being kind of charity, kind of government-supported charity. You could think of it as being 100% subsidized insurance from another point of view. Medicaid essentially was built on that federal patch to state-based indigent programs. The states run it. The federal government covers 50 to 80% of state costs. If a state has Medicaid, it's required to cover certain groups like poor families on cash benefits, people who are getting disability money from the federal government, including aged people who are, in Social Security, people who are blind and disabled. But other groups were initially optional. Medicaid's referred to as an entitlement. What does an entitlement mean? It sounds kind of bad to be entitled, but what it really means here is that if you are in the group of people who qualify, you get it and you get all the benefits attached to it. There is not a fixed dollar commitment from the federal government. If there are more sick people, if there are more old people, if there are more costly treatments that suddenly spring into being, if there's an economic downturn and suddenly lots of people need to apply for this thing, then the federal government, coupled with the states, are pretty much on the hook to spend more money. So that's what defines an entitlement. Medicaid was expanded in the 1980s to include pregnant women and children, particularly if the family was poor. Many states reached to help more pregnant women, including in California. They went up to 322% of the federal poverty level to make sure essentially every pregnant woman had insurance during the pregnancy. There's also coverage of children who were in families that were making less than the federal poverty level. Not necessarily their parents. We'll come back to that. One thing to keep in mind with Medicaid is that healthy kids are not very expensive. It's really the disabled and the elderly adults who tend to cost the most to take care of. In 1997, after the Clinton plans to expand healthcare failed, the Children's Health Insurance Plan was passed. And this involved using federal dollars to help insure kids who are above the federal poverty level. It could be set up as an expansion of Medicaid or as a separate program in a given state, and CHIP usually reaches up to capture kids whose families make between 200 and 300% of the poverty level. It's variable. States can make their own decisions. And it certainly helped reduce the percentage of kids who are uninsured from 14% in 1997 to 7%. This graph is merely meant to remind you that for kids, Medicaid, which is the green pie chart, covers 39% of children in America. Medicaid's a big player for nursing homes. 15% of the United States is over 65, and that number is going to rise. 1 in 3 of those older adults are going to need nursing homes at some point. Medicare only covers short-term rehab for a limited amount of time. So ultimately, for many of those adults, if they don't have special plans or a lot of independent money to use, they're going to wind up relying on Medicaid. Again, there's no fixed limit on how much the federal government has to spend. And there's a graph there from Kaiser Family Foundation showing how many nursing home residents are covered by Medicaid. Roughly half of childbirths in the United States are financed by Medicaid. Darker states here are the ones where over 54% of the childbirths are funded by Medicaid. So it's a big player on that front. And finally, as most people know, Medicaid was expanded under the Affordable Care Act so that the states that wanted to take advantage of this could include people who were making up to 138% of poverty, including single adults who weren't in the original Medicaid arrangement. 32 states took this up. In 2016, the cost of the expansion was $74 billion. And that's quite a bit of money, obviously. Medicaid grew in terms of the number of people it served. I think, again, the figures here go all the way to 2017 and include the CHIP patients. So you see a figure that rises from almost 57 million to 74.5 million people. That's a big growth because of the Affordable Care Act. Another key component now that we've been seeing a rise of opioids in the United States is how laws have figured in covering people through Medicaid. A law was passed in actually a little bit before 2010 that required parity of addiction and mental health care in insurance plans so that an insurance plan couldn't give worse coverage for mental health or addiction than it did for medical problems, as long as they were covering mental health and addiction at all. The Affordable Care Act essentially extended that to all the new group and individual plans sold on the exchanges, to Medicaid, and to the CHIP program. Today, in 2017, 25% of all the medication treatments for opioid addiction come through Medicaid. And that's actually 50% in Ohio, which is one of the epicenters of our current crisis with opioids. Sometimes you'll hear expression the Medicaid gap or the gap in coverage, and this graph from the Kaiser Family Foundation is meant to explain it. On the left-hand side, you can see that people who are poor, particularly poor families and poor children, would have access to Medicaid. Poor single adults typically do not unless they're in one of those states that expanded Medicaid. Then there's this group of people who are making less than 100% of federal poverty level, where their state has not actually expanded Medicaid. And they are in a kind of gap. They don't get the Medicaid that's for the very poor families and kids or for the disabled, and they are making too little to get a subsidy to purchase private insurance on what are called the exchanges. Because when Congress passed the Affordable Care Act, they just figured that anybody under 100% of federal poverty would be on Medicaid. Once the Supreme Court ruled that states didn't have to take that option, this group was left in the gap. That means that in those states that have not taken Medicaid, they have their own rules about who might be able to take it on without using the federal expansion option. And what you see on the left-hand side here is the percentage of federal poverty income that a parent of a child would need to have in order to qualify. So if you look at the very, very bottom of the left-hand figure, you see that in Alabama, parents who are poor and make less than 18% of the federal poverty level, which would be just a few $100s a month, can actually get Medicaid. Pretty hard to qualify though, all the way up to, as you see, Maine, where parents who make 105% of federal poverty level, as long as they're parents, they actually do qualify for Medicaid. Childless adults are a whole different matter, and as you see on the right-hand side, there's really no level of poverty at which a childless adult can qualify for Medicaid in most of these states, save for Wisconsin. Obviously, if they're disabled and they have federal disability, they actually can qualify for Medicaid, but not otherwise. A big focus has been on the idea that managed care organizations can actually pay for Medicaid. The traditional arrangement with Medicaid is that states write the checks that for typically a low fee to doctors and to hospitals to take care of their patients. But nowadays, at least for typical adults and kids, managed care programs cover about 70% of the beneficiaries. The old population, older folks, disabled individuals, and the very sick still tend to be in those fee for service arrangements where the state essentially writes a check for every service rendered. The promise for managed care organizations is that they could impose a measure of accountability. They could manage the population's health and look at the health of, for particular conditions like diabetes and see if things are being standardized and impose some disciplinary savings in terms of expenditure. The reality so far, at least in most studies, not everyone, but has been that there has not been a lot of cost savings associated with using managed care for Medicaid, although some people would disagree. Sometimes costs actually go up from managed care organizations. I recently visited a community health center, which takes care of the poor and the homeless, who were spread across 9 different managed care organizations. Well, guess what? When you need to refer a patient for a specialist with 9 different managed care organizations, somebody has to take responsibility to make that happen. Of course, they had to hire several additional employees to do the work, and that is not a very efficient way to go in certain ways. Why have Medicaid managed care organizations not tended to save a ton of money? Part of it has to do with the reality that thus far, the rate of growth in expenditure per enrolled person in Medicaid has typically been lower than in Medicare or in private health insurance. That's the blue bar on the left. This is partly because states have typically exerted pretty tight control on how much they spend and what kinds of benefits they allow, because frankly, they have to balance the budget every year, and states are on the hook for a significant part of Medicaid expenses. Setting up new bureaucracies as well for managed care, et cetera, tends to cost money, so it may not be possible to extract a lot more savings, but that is a debated point, and in some states, certain programs have done a very good job. In 2017, several proposed Republican changes to the Affordable Care Act, efforts to repeal it mostly, talked about the idea of something called the per capita cap, and that is complete jargon that no one would normally understand. But essentially, what it is an effort to fix the amount of federal dollars that are spent per patient who's been assigned to Medicaid, rather than let it be an open ended obligation. The idea was to essentially say, look, we know how much people costed in 2016. We'll allow that amount to grow by a certain formula, and you, whatever state you are, figure out a way to run your program so you can deal with the amount of money that we're going to send to you. The projected growth under that plan, at least according to a group called MacPac, which seems pretty objective, is that it would be kind of a lower rate of growth than normally would happen for the disabled, for kids, and for those traditional Medicaid adults before the Affordable Care Act passed. But on the other hand, they said that the rate of growth for each individual might be the same or perhaps even higher for older disabled individuals and newly eligible people for Medicaid, folks who came in under the new Affordable Care Act provisions. Generally, the argument has been, according to the Congressional Budget Office, that this would result in cutting the projected expenses for Medicaid by about $800 billion over about a decade. From the standpoint of a liberal, one might say, look, that's a big cut. Conservative might say, it's not really a cut. The funds are growing, just not at the rate you might have expected. The projection, at least from those who oppose this type of approach, is that the states may handle the constraints by restricting services, by stopping things like home attendance for people who are disabled. They might charge additional premiums for care. They might impose waiting queues, or even cap the enrollment in the program. Obviously, whether that happens depends a lot on what Congress chooses to pass. That's the end of this talk. I hope it's given you a useful background on Medicaid. Some links are shown. I've mentioned MacPac, the Kaiser Family Foundation, and Medicaid.gov as just a few places you can look to learn more. Thanks for your attention.